Good evening, everybody. Thank you very much for this kind invitation. Dear colleagues, friends, it's a great pleasure and honor to be part of this very prestigious, high qualified team. My task today is to present the collecting system injury, one of the more common complications in PCNL. When we talk about the collecting system injury, I think we need to define when this can happen and how this happens. And then I'm going to be talking about the consequences and management of collecting system injury with its various manifestations, and then how to prevent this complication. I think it's a very common occurrence in the complication spectrum, because this can happen at all phases of PCNL. This can happen during access, tract dilatation, working sheath placement, stone removal, if there is a tumor resection and not the stone, but a percutaneous level, or nephrostomy tube insertion and removal. So this is a very common occurrence, and has to be alert. You have to be alert of this complication throughout the procedure. It's not uncommon. It's about up to 8%. It's been reported from 2.3 to 8% of occurrence. And this happens secondary to intrarenal pressure being high during the procedure, overdilation when we go too deep with our instruments, especially if we do it only by feel with no fluoroscopy, using the stiff wire usage or use going through, and the access sheath. And also when we are trying to deal with a tough stone, the rigid nephroscope, overzealous use of that, and the extreme angulation, which can tear the system throughout. Another not uncommon, but we don't see it, and sometimes we see a delayed manifestation of it, is energy-related injuries because of the different source of energies we use. This complication, the collecting system injury, can result in several manifestations. One of the most common is the stone migration, renal pelvic injury, ureteric injury, and also more commonly extravasation with fluid absorption, and urinoma formation. So we're going to go through different, each one of them, and what we're going to do with each. So the stone migration, this is not uncommon. It's extrarenal, extraureteral, depending on the location. This is usually not significant. We do not retrieve, as going after these stones might make this perforation much bigger and will make the problem even worse. We are tempted, if it's visible and with no harm, we can pull a few, because it can confuse the picture in the future when we image these patients. However, it's not significant unless there is an infection element, and also if it's very close to the ureteric collecting system, and it can cause stricture in the future. I think, as Dr. Paul said, we have to be artists, we have to be gentle. It's very important to, when we go after the stone, to be as gentle as possible and not to initiate or push the stone through the system to cause this migration. What about renal pelvic injury? This actually is not uncommon. Also, it varies between a minor, which is not, sometimes you hardly see it, or massive injury. What do we see? What are the signs? When you encounter perinephric structures or fat, this shows there's a big gap. Also, when you inject contrast on fluoroscopy, any abnormal hemodynamic parameters, this can be the cause of this. And also the more the reduction in the irrigation fluid drainage through your sheath. Usually the minor extravasation do not require early cessation of the procedure, and also we continue by modifying our sheath and the location of our working environment. But however, the large disruptions, including the perforation of the renal pelvis, a lot of the experts advocate should prompt cessation of the procedure, and we put a nephrostomy with a stent if possible, and percutaneous drain if needed, or anticipate there will be a large collection. The drain should be staying for at least a week, so we'll ensure that there's no residual collection. This is a video I'm going to show of a large perinephric extravasation. And also, if you look, you're going to see shortly, there's a fragment, you see a stone migrated out, and you can see the sheath trying to pull the sheath to go back so it can go back into the system. And obviously, this is a large rent into the pelvis. And also, you can see the vision is not very clear because not a lot of fluids are coming back. So you're getting this multitude of signs of that you've got a large perforation. What about ureteric injury, which is the second thing we worried about? It's not uncommon to have ureteric perforation, or unfortunately, which is very rare, avulsion of ureter. This can happen when you try to integrate basket or trying to into this fragment a large stone with a lot of force, and this is impacted, or when you're trying to do an incision or dilatation of UPJ or tumor section. Another something you have to keep in mind is the energy sources. These are capable of doing perforation, hemorrhage, thermal injury, which can show in a delayed fashion. With all the instruments we have, being it laser or ultrasonic lithotripsy or a pneumatic lithotripsy, these can cause damage, and we have to be very gentle with using these and when to push and when to back off. Usually, if we can recognize the injury, we insert a double J, and also as a safety, a nephrostomy tube will be very advisable. If an anticipation of a urinoma is, especially if there's a large tear, a drain will be useful, and the procedure should be aborted with a nephrostomy. If, unfortunately, avulsion happens, this actually will require prompt open surgical exploration. So we come to the extravasation, which is another consequences of collecting system injury. The problem with extravasation is the absorption of irrigation, which can lead to so many complications, and it's very difficult sometimes to quantify or actually to diagnose these, especially if the patient is under GA. But I think it's an important message for all of us. When we find and we discover this extravasation, I think a heads up to the anesthesia should be there. You should tell the anesthesiologist that we have such a situation, and you continue if it's, of course, safe. And then they have to look for the electrolyte abnormalities, and if there's any intravascular volume overload or hemolysis. And then you have to, afterward, examine the patient for any signs of peritonitis or ileus. The absorption is actually, it's very dependent on the pressure, the procedure length, and the sheath system used. We always advocate an open sheath system rather than a closed system. Otherwise, this will not, most of it will not come out and all will be entrapped. And we'll show a perforation with extravasation of fluid, and this is fairly limited. It's you can see the perinephric fat. It's not a problem to pull back with the sheath and actually direct it somewhere else while you finish your procedure. This is a nice picture of showing the extravasation with a massive leak through the renal collecting system with CT with contrast. So what I suggested and divided these into two main categories, the extraperitoneal and the intraperitoneal. The extraperitoneal or retroperitoneal is more common, and usually it's quite limited with the retroperitoneal space and structures, and usually you can proceed, and usually it's contained. The less common but more serious and actually can lead to a lot of complications is the intraperitoneal. When this happens, and the problem initially on the table, it's very difficult to recognize this as patient is prone, and you cannot assess the abdominal distension. You get an abdominal hypertension, which can lead to abdominal compartment syndrome when your pressure is over 20 millimeter of mercury. It starts with 12, this goes there. Diastolic blood pressure going up with wide narrowing of the pulse pressure, increase in central venous pressure. All these you have to mention to your anesthesiologist that this is happening so they can follow up with you. And also when they tell you there's a difficulty in ventilation, this is an important time to stop and then to reassess what's going on. And also reduction of urine out. The early recognition is key. So you stop the procedure, you apply diuresis, and you put a peritoneal drainage, and possibly sometimes you might need a laparotomy, especially when you encounter the abdominal compartment syndrome. This is a nice cartoon showing that with this arrow going into the anterior layer, which is fused with the peritoneum, and then when you have this gush of irrigant fluid, this will actually will pour into the peritoneal cavity with the consequences we mentioned earlier. And this you can see, it's a very distended abdomen, stony hard, despite having a nephrostomy and it's actually draining. But this patient moved to have a drain, peritoneal drain, in order to decompress this. What do we do when we have these kind of perforations? Especially intra-op is very important, very key to diagnose these. You want to keep the procedure as short as possible. You want to reduce the low flow pressure. You want to do a low flow pressure, especially if you have a pump, or lower down your bag. There are some evidence that it's advisable to abort the procedure if there's more than 500 ml of irrigation used and gone through. You drain the system with a double J and nephrostomy, and depending on where the perforation was, you can put an abdominal retroperitoneal drain, which can be assessed postoperatively. Another complication we see is the urinoma. When you have a collecting system injury with extravasation fluid, urine can actually follow as well, and this will eventually form into a urinoma. It's not very common. The reported cases are 0.2%. However, it's important when you anticipate this to provide adequate drainage with nephrostomy and double J, and drain the site of urinoma if you feel this is going to happen. What we do, excuse me, in the postoperative period, usually this is a delayed presentation. They might get a flank pain, fever, abdominal distension, and ileus. This should raise suspicion of the extravasation and formation of urinoma. You can also watch for infection parameters, and then you can actually put the percutaneous drainage and drain the collecting system with nephrostomy and stent. And you can see clearly with this image that there's on the left-hand side the urinoma collecting around peripherically, and then this is post drainage and clearing of this urinoma. This is a nice image showing a bilateral staghorn stone with 1.7 creatinine. I underwent left PCNL somewhere else and presented with raising a renal creatinine, and on RGP you can see a nice cystic mass with fever with rigors over 1 month, and this was drained, and bilateral double J stents were put. The picture on the left side, and you can see the drain here and bilateral stents. And this was difficult to insert on the left side. Obviously, there might be some edema or some injury of the UPJ. On 5 or 7 days later, the drain was producing nothing. This was pulled out, and then the right PCN was done with good results. I think as a principle, you can see it from this cartoon that the urine and water always flow through a passage of least resistance. So I think you have to anticipate these. And another very important thing, even if we clear the stone, it's important to go back and check the system. Always do inspect your system before even leaving or closing off. Because this is actually, it might show you a perforation, might show you an injury that you didn't anticipate or you did not expect while you're doing, especially if it's a large stone or staghorn. So the general principles for managing the collections are very simple. Drain the collection, make sure there's a free passage of urine through a ureteric stent and nephrostomy. Being, if you need to put preemptively, or you need to put all these three together, it's important, and this actually reduces the morbidity and sometimes mortality of these patients. I think we come to the prevention. How do we not to get this complication or to reduce the impact of this complication? It's important to have a precise access and dilatation technique. As Dr. Pal just showed us, sometimes under dilatation is safer than over dilatation. It's very important to use the fluoroscopy for percutaneous access and also dilation. The stone fragmentation, with experience, it has to be very gentle, however, not to pushing the stone or using the stone. The stone can actually cause a lot of damage while you're trying to apply lithotripsy in different formats. And also we should use isotonic irrigation fluid. Very important, I think most people are using open or continuous irrigation system to reduce the rate of extravasation and fluid absorption. Fluoroscopy for nephrostomy tube insertion or removal is very advisable. And I think very important message, and this is the one I'm going to conclude with. Please, please, please be alert to all stages for this possible complication. And it can happen in any stage of this procedure.
Can you summarize, Dr. Latif?
Thank you very much.
Okay, thank you. Okay, Dr. Latif, just don't put off. Show that particular slide where you have shown all the layers and the coverings.
Sure.
Just go back to that. And anyway, we will be having question and answer. Questions can be sent onto the chat box, and we'll be, this particular slide.
Yes.
Here, I just wanted to, you have mentioned about extraperitoneal as well as intraperitoneal.
Sure.
Here, I would like to clarify, see, you presume that this is the kidney and it is, and and we are coming from posterior aspect, going deep, deep, deep. It is only at the upper pole, upper one third of the kidney,
Mhm.
where there is a direct attachment of the peritoneum. And if you go in the upper pole through and through, from the posterior parenchyma to the pelvic ileal system to the anterior parenchyma, and then go deep,
Mhm.
only then you can produce a intraperitoneal leakage of fluid. Even a gallbladder injury or the duodenal injury can take place only when you are through and through come to the anterior relations of the kidney. As
Yes.
long as you are in the lower two-third of the kidney, anteriorly there is a fat, there is a colon, there is duodenum, all those retroperitoneal structures are there, and the fluid, if it extravasate, it will not go intraperitoneal, it remain anterior but here only. Just
Yes.
wanted to clarify this particular thing. And you have given a very right message. You can now stop your screen sharing.
Sure.
And the message is very clear. We have to be very, very, very careful. Under dilatation or remaining superficial is still much better. You can redo it. If you are lost, leave a tube, come out. Next time when you will go in, the tissues will be well organized, and you will see it will be very smooth sailing.